Good afternoon, class.
Good afternoon,
sir.
Good afternoon, sir.
I hope you are all doing great.
By His grace and you.
So this afternoon we shall be discussing the subject wound healing, tissue repair, and regeneration. There is the outline of the presentation. We will attempt to define what wound healing is, look at the various types of wound healing, so regeneration and tissue repair, and then look at their mechanism of what? Healing by first intention, mechanism of healing by second intention. We'll examine the factors that delay wound healing and the complications of wound healing, and then we'll solve some MCQs. So what is wound healing? Okay, wound healing is the body's response to injury with the intent of restoring normal structure and function. So as we define inflammation, vascularized tissue response to injury, okay? So once there's inflammation, it should end in what? Wound healing. There should be restoration of what? Structure and function, and that is what we call wound healing. Now, it involves two distinct processes. We have regeneration and then repair. Regeneration, which is restoration of the normal structure, and then repair, whereby the tissue is replaced by scar tissue or connective tissue. Okay. So we shall look at them one by one. So as I've already said, in regeneration, it leads to complete restoration of the original tissue. And the healing takes place in two ways. Okay. So the first way is that there's proliferation of the parenchymal cells. It could be the residual or the uninjured cells that have retained their capacity to divide. And then two, the injured cells may be replaced from the stem cell. Okay. So either is there's proliferation of the remaining parenchymal cells, or there's replacement of the tissue from the tissue stem cell, the progenitor cells. Now, regeneration, that leads to complete restoration of the tissue structure and function, typically occurs in tissues that rapidly divide. So you look at the epithelium of the skin and the intestine, okay? So we shall examine tissues and classify them on the basis of their ability to proliferate. So based on the proliferative capacity of tissues, they are classified into three groups. So we have the labile cells, the stable cells, and the permanent cells. So these are high yield in exams, so I want you to pay attention, okay, with these slides that we'll be looking at. So what are labile tissues? So these tissues are continuously being lost and replaced. These tissues can rapidly regenerate after an injury as long as the stem cell is preserved. Okay, so they are rapidly being lost and they rapidly divide. These cells have the capacity of what? Proliferation. So what are these cells? So examples are the hematopoietic cells in the bone marrow. So surface epithelium. Okay, so if you consider the oral cavity, the vagina, which are lined by what? Stratified squamous epithelium. If you look at the genitourinary tract, they are lined by what? Transitional epithelium. So all these surface epithelium that we've mentioned have the capacity of replication, of proliferating. And so they undergo what? Regeneration, complete restoration of structure and function. Please don't distract the class. Please don't distract us. Those talking should be muted. So in exams, you can be asked to identify the liver cells, and we'll give you a list of tissues, and we'll say which of these, okay, is classified as a liver cell. You are supposed to pick any of these. If there's hematopoietic cells of the bone marrow or surface epithelium, okay, that covering the oral cavity and vagina, stratified squamous epithelium, that covering the genitourinary tract, transitional epithelium, the surface epithelium of the gastrointestinal tract, the uterus, the fallopian tubes are lined by the columnar epithelium. Okay, the cuboidal epithelium that lines exocrine organs like the pancreas, the biliary tract, and the salivary gland. So take note of these examples high yield in your exam. Then we have stable tissues. So what are stable tissues? We are examining or classifying cells based on their proliferating capacity. We've dealt with what? Labile cells. Now we are moving on to stable tissues. So what are stable tissues? These cells of these tissues are in quiescent phase of the cell cycle. We'll do cell cycle so you understand the quiescent phase. And these tissues have minimal replicative activity in their normal state. However, they are capable of proliferating in response to injury or loss of tissue mass. Okay? So example of stable cells are the parenchyma of most soft tissues, like the liver, the kidney, and the pancreas. And then the mesenchymal cells, mainly the endothelial cells, fibroblasts, and smooth muscle cells. So those are stable cells. Know the examples. Parenchymal cells of what? Soft tissue, liver, kidney, smooth. Those are all stable cells. Okay, the mesenchymal cell, fibroblasts, and so on. Know the examples. Then we have permanent tissues. So these are non-proliferative in the postnatal life. And they heal by fibrosis or scar formation. They are unable to regenerate. So the permanent tissues cannot regenerate. They heal by scar formation or by fibrosis. For example, we have the neurons, the cardiac muscle, the skeletal muscle. So all these are what? Permanent cells. They heal by what? Scarring. So the neuronal tissue, the cardiac muscle. So take note of the example. Before we move on, give examples of labile cells. Any of you, examples of labile cells?
Say hemato.
Good. So hematopoietic cells of what? The bone marrow. What else?
Transitional epithelium.
Yes, the surface epithelium of various organs. And you've given an example of a transitional epithelium of the genitourinary tract. Excellent. How about stable cells? Stable cells. Can you give examples?
Parenchymal cells of soft tissues.
Yes. Parenchymal cells of soft tissues.
And mesenchymal cells.
Example of the parenchymal cells of soft tissue. Example. Which organ?
The liver.
The liver.
The kidney.
The kidney. Good.
Pancreas.
Very good. How about permanent cells? Can you give examples?
The cardiac cell.
The cardiac muscles.
Very good. And then what? Yeah.
Skeletal muscles.
Uh-huh.
The neurons.
Skeletal.
Neuronal tissue. Very, very important. How do these permanent cells heal? They heal by, is it regeneration of scar tissue?
Scarring. Fibrosis.
Yes, by scar
Fibrosis
formation.
or scarring.
How about the liver cells? Is it by scarring or regeneration?
Regeneration.
Yes, regeneration. So I'm happy you've been able to get it. So I hope in exams you can replicate it. Okay.
Yes, sir.
Now, cell proliferation is driven by signals. Okay? And these signals are provided by growth factors and the extracellular matrix. So you should know what drives cell proliferation, or mainly what? Growth factors and the extracellular matrix. And the most important source of growth factors are the macrophages. They are very important source of what? Growth factors. Epithelia and stromal cells also produce these growth factors, but chiefly they are produced by the macrophages. So remember that on this slide, what I want you to take note is that the cellular proliferation is by the growth factors. So signals from the growth factors. And growth factors are chiefly produced by the macrophages. So those are the things to take note of. Okay, now let's look at tissue regeneration. The mechanism. We are examining regeneration, how the tissue restores its structure and function, okay, when it's injured. We are using the liver regeneration as a case study. Okay, so remember that when we were doing cell adaptation, we spoke about what? Hyperplasia. Hyperplasia, adaptive hyperplasia, or compensatory hyperplasia of the liver when there's partial hepatectomy. So when a portion of the liver is resected, over time, the liver structure is restored. And we said that is by the process of what? Hyperplasia, if you remember. Okay,
Yes.
so we are going to re-examine how the remaining hepatocytes proliferate to replace the lost ones. So regeneration of the liver occurs by two main mechanisms. Number one, which we've already mentioned, is proliferation of the remaining hepatocytes. Okay, so you've resected a portion of the liver, and the remaining hepatocytes undergo cellular proliferation to replace those that have been lost. And then we shall also look at when the injury is very severe, that the cells lose their capacity to replicate. What happens? Then there's the cells that rely on what? The progenitor cells, the stem cells, to repopulate the remaining cells. So let's look at the first mechanism in which there's cell injury has occurred, the liver has been partially resected, and the remaining hepatocytes undergo what? Cellular proliferation. So let's look at the details. So the details, we have the priming phase, the growth factor phase, the termination phase. So let's evaluate these ones in this diagram. What is the name given to the macrophage that is found in the liver? What is the name given to the macrophage found in the liver? You said macrophages, they are given special names in special tissues, isn't it? You remember. Mhm. And the inflammation, we spoke about this, chronic inflammation. So macrophages found in the liver or the hepatocytes are called
Interferon-gamma.
Interferon gamma.
Interferon gamma.
what the most about
Copper cells.
Copper cells.
the body is you mean that you don't read your notes.
They have been reading though, but they have
The other group is
specifically
not
touching them.
your other group, they got it correct. All of them shouted synergistic and they said what copper cells. But you are saying interferon gamma. Hey, they do. So that's copper cells.
Copper cells.
So the macrophages called copper cells in the hepatocytes, they secrete interleukin 6. And interleukin 6 primes the hepatocytes. Okay, in priming, which simply means that the hepatocytes acquire receptors. So interleukin 6 produced by the macrophages primes the hepatocyte, the liver cells. Once they are primed, they now carry receptors. So you can see that the second hepatocyte, they carry receptors. Some are green, some are orange. And these receptors, the growth factors bind onto these receptors on the hepatocyte. Once the receptors on the hepatocytes are bound by growth factors, cell proliferation begins. Okay, so the cells were quiescent in the G0. Now they've moved to the next stage of the cell cycle G1, and there's what cell proliferation. So the hepatocytes are proliferating. They proliferate until the liver structure is restored. Now, once the liver structure has been restored, the next phase is the termination phase under the influence of what? Transforming growth factor beta. Okay? So, under the influence of transforming growth factor beta, the proliferation phase is terminated. Other than that, the cell proliferation will be ongoing. But you've been able to achieve or restore the structure of the liver. So it has to end. And the termination phase is under the influence of transforming growth factor beta. Any questions? Do we understand it?
Please, sir, the parts where it returns to the quiescence, I didn't get.
Oh, so very simple. So macrophages, it starts with the macrophages. The macrophages, so we have the priming phase. The priming phase, the macrophages are key. They secrete interleukin 6. They prime the hepatocyte. The meaning of being primed is that they acquire what receptors. So the hepatocyte, they acquire receptors, and transforming the growth factors bind to these receptors. Once they bind to the receptors, okay, they are switched. The hepatocytes, which were in the quiescent phase, you haven't done cell cycle yet. We will do it. Okay. But G0 simply means that they are quiescent. The cells are quiet, they are not replicating. Okay. Now, once the growth factor binds to the receptors, there's a switch to the G1 phase of the cell cycle, in which there's cellular proliferation. Okay, so the hepatocyte begins to proliferate until the liver structure has been restored. Then the next phase is the termination phase, in which the cellular proliferative activity ceases. And I said it's under the influence of transforming growth factor beta. Okay.
Thank you, sir.
So anybody to explain the regeneration, the liver regeneration? the priming phase, the growth factor phase, the termination phase. Anybody who understands it a little? Anybody understands it just a little in your own language? Oh, not even one person. The other group, about 3 people tried it. And they did very well. So anybody, any one of you.
Sir, please, I'm trying.
Yeah.
You said that the priming phase, that's the phase that they have to acquire a receptor. They need to get receptors, and then when they get the receptors, the growth factors will come and bind to it. The genotes mean that they are in the quiescence phase, and then they are not proliferating. Quiescence. But then when the gene one phase, they will begin to proliferate. That's how I.
And how does the proliferation end? Under the influence of which?
Interleukin-6, growth factor interleukins.
We said transforming growth factor beta.
Transforming growth factor beta.
Yes, isn't it here? So by the transforming growth factor beta, the proliferative phase ceases, isn't it? Yes.
Yes, please.
So the liver structure is restored in 2 ways. We spoke about what? Proliferation of the remaining hepatocytes, isn't it? Yes. And then 2, repopulation by what? The stem cells or the progenitor cells. Okay. Good. And this happens when there's when there's chronic liver injury or when the inflammation is very severe. Okay. And the proliferative capacity of the hepatocyte is impaired. That is where the progenitor cells or the stem cells helps to repopulate the remaining cells. Okay. So very simple to understand. Now let's look at repair. Repair simply means that you are replacing the injured tissue by fibrous tissue. Okay, so the damaged site or the damaged tissue is replaced by scar. The scar tissue patches the damaged area. Okay, so tissue repair is mainly by what? Scar formation. Now let's look at the steps involved in scar formation. You have to be conversant with the steps. Okay, so assuming you are cut with a knife, what happens? The body would attempt to stop bleeding. So there's formation of a hemostatic plug to stop the bleeding. Okay, so that's the first step. Then the second step is that there's what? Vascularized tissue response to injury, there's inflammation. So when there's a cut, initial formation of what? Hemostatic plug to reduce what? Or to stop the bleeding and to provide a scaffold for the deposition of fibrin. Now, after the formation of a hemostatic plug, is followed by what? Inflammation. The inflammatory phase is followed by cellular proliferation. So which cells proliferate? We are looking at remnants of the injured tissue, the vascular endothelium, and then fibroblast. Okay, so these cells proliferate. Now, after cell proliferation, there's a formation of granulation tissue. So granulation tissue is the hallmark of wound healing. Okay, granulation tissue formation is the hallmark of wound healing. So you have new vessel formation, which is angiogenesis. New vessels form from pre-existing vessels. Okay, and then because these vessels are leaky, there's what extravasation of fluid into the interstitium. and that leads to what? Edema. Okay, very important. So that's how come granulation tissue looks pink, because of what? Angiogenesis that is taking place. Formation of new blood vessels from pre-existing ones. Okay, and there's what? Fibroblast deposition. Now, after formation of the granulation tissue, there's deposit of what? Connective tissue. Collagen. Deposition of what? Connective tissue and then scar formation. So these are the steps involved in scar formation. So remember we said in the formation of scar, it starts with what? What does it start with?
Hemostatic plug.
Yes, so if you are cut, there will be a hemostatic plug with the intent of what? Stopping the bleeding, isn't it? Yes. So after the hemostatic plug, what process will take place?
Inflammation.
Yes, inflammation. Very important, which we've already done. So I don't want us to go through it again. So there will be inflammatory response. Very key. Now after inflammation, what's the next step?
Cell
proliferation.
So fibroblasts will proliferate, the vascular endothelial cells will proliferate, and then the residual cells of the injured tissue will also proliferate. Yes. Then the next step is what? Formation of
Granulation tissue.
And I said that the granulation tissue is the hallmark of what? Wound healing. Yes. So once you see granulation tissue, they are pink, they are granular. Okay. They are pink because of the new blood vessels that have been formed from pre-existing vessels. Okay. And these vessels are leaky. So you see that there's some edema associated with what? Granulation tissue. Because the new blood vessels that are formed have leaky walls. So there's extra interstitial. Okay. Now, after formation of granulation tissue, what's next?
Deposition of connective tissue.
Yeah, connective tissue deposition. Very important. So connective tissue deposition and then scar tissue forms, isn't it? Yes. Now on this slide, I want you to remember we've done macrophage activation and chronic inflammation. Remember we said that we have macrophages that are activated under what? The classical pathway and those activated by the alternate pathway. Okay? Which of the two is involved in wound healing or tissue repair? Which of the two types of macrophages are involved in tissue repair?
Alternate.
Good. So macrophages which are activated by the what? Alternate pathway. Which of them is microbicidal?
Classical.
Yes, those activated by the classical pathway are microbicidal. I'm happy you remember this. So now, because we are done with inflammation, we are concentrating on what? Wound healing now, isn't it? So if it's wound healing, which of the macrophages are we looking at? So macrophages activated by the alternate pathway, isn't it? Someone is disturbing the class. So that person must be muted. Please be muted. Good. So macrophages activated by the alternate pathway, they are involved in tissue repair. And we made mention of two cytokines that are anti-inflammatory, which are
interleukin 10.
And then transforming growth factor. Yes, transforming growth factor beta. I've already mentioned angiogenesis. Let's attempt to differentiate angiogenesis from vasculogenesis. In angiogenesis, there's what? New blood vessel formation from pre-existing vessels. Okay? But with vasculogenesis, it's the same thing. There's new blood vessel formation, but that happens in utero, in the womb. Okay? And it occurs in the embryo. Okay. Now, why does new blood vessels form during wound healing? These new blood vessels supply the area, the injured site, with what? Nutrients and oxygen. And that supports what? The repair. Okay. Now, angiogenesis takes place under the influence of these factors. So you have to take note of these factors for examination purposes. So angiogenesis takes place under the influence of the vascular endothelial growth factor, the platelet-derived growth factor, the transforming growth factor beta, and the fibroblast growth factor. Okay. So take note of these growth factors that influence angiogenesis. Now, let's look at transforming growth factor because of a question I brought in your exam. So I want you to look at the transforming growth factor. Remember, we've mentioned one of its attributes that is anti-inflammatory, isn't it? Yes, aside that, it also stimulates fibroblast migration and proliferation. So fibroblast migration and proliferation is under the influence of the cytokine transforming growth factor beta. Apart from that, it has other functions which you can look at later. So let's look at the granulation tissue. So you can see a picture of the granulation tissue. It looks pink, granular in appearance, okay, on the surface of the wound. You can see. This is also another image of a granulation tissue, okay. So this one has numerous blood vessels, making it look what, pink or red. That's a lot of inflammatory cells. Remember I told you there may be edema and then what? Fibroblast proliferation. So there is a histological appearance of what? The granulation tissue. It looks pinkish. There are areas of edema, a lot of small or new blood vessels, making it look red or pinkish. So the term granulation tissue is derives its name from slightly granular and pink appearance of the tissue. So it's slightly what? Granular, and then it's pink in appearance, which was already mentioned. And each granule corresponds histologically to proliferation of new blood vessels, okay, that are slightly lifted on the surface, slightly lifted on the surface by thin covering of what? Fibroblasts and young collagen. So as healing progresses, fibroblast proliferation and the new blood vessel formation decreases. However, there's increase of collagen deposition, and that leads to what? Scar formation. Okay. Then wound contraction is under the influence of what? The myofibroblast. So in MCQ situation, if we list a number of items and we ask for what accounted for the contraction of the wound, okay, research has shown that it's due to the myofibroblast. The myofibroblast causes wounds to contract so that the wound will reduce in what? Size. It shrinks in size. So when there's wound healing, you will see wound contraction. And the wound contraction is as a result of what? Myofibroblast. So let's look at skin wound healing. So we'll consider healing by first intention and then healing by second intention. Okay. So the healing by first intention is also known as healing by primary UDL. The healing by second intention is also known as healing by secondary union. So healing by first intention, the injury usually involves only the epithelial layer, okay? And the wound is what? Clean, it's not infected, and it's usually from a surgical incision that has been approximated by what? Sutures. Now, if you look at healing by second intention, usually the wounds are large with a large what? Tissue deficit. So let's look at healing by first intention. We said that usually the wound is what? Clean. And it's due to surgical incision, okay, that have been what? Reapproximated with what? Sutures. Okay, so look at this one, clean what? Cut with a knife or scalpel blade, okay? So we are looking at healing by first intention. The wound is clean, it's an uninfected surgical incision. Now, if you look at the stages of what? Scar formation, what's the first stage?
Hemostatic plaque.
Yes. So you can see, if you follow this diagram, within the first 24 hours, the immediate response is what? The formation of a hemostatic plug. Okay. Then within the first 24 hours, inflammation will what? Set in, isn't it? Yes. So there's inflammation in the second process. Now, by the third to the seventh day, granulation tissue starts what? Forming. And this one I want you to take note because it's in your exams. By day 3 to day 7, within the first week, you should expect to see what? Granulation tissue. So in your MCQ, if you are asked, you should be able to give a good account of yourself. Okay? If you know that on the 3rd to day 7, you should expect to see granulation tissue. Okay, so in the subsequent weeks, there's the position of what? Connective tissue. The more connective tissue deposition, okay? Now, the type of collagen that is deposited is a type 1 what? Collagen. So you should take note of the type of collagen that is deposited. Now, look at the healing by second intention. The defect is big, isn't it? And usually, there's a large tissue deficit. Because the defect is huge, the hemostatic plug is also what? Large. So you can see the hemostatic plug that is formed, okay? Now, the same things that happen in the primary intention in terms of the steps involved in scar tissue formation, okay, they are the same, okay? So just that the tissue deficit is large compared to that occurred in the healing by first intention, okay? Then if you're looking at the granulation tissue formation, it's huge in the healing by second intention. Why? Because there's a large tissue deficit. So the granulation tissue deposition is also what? Very large. Okay. So you can see numerous blood vessels, numerous inflammatory cells, okay, deposited compared to healing by what? First intention. And if you look at the scar tissue, the scar tissue in healing by second intention is larger compared to that of what? Healing by second intention. Please, do we understand?
Veronica Boachi, please mute yourself.
At the background. So this slide, I want you to differentiate the healing by first intention and from the healing by second intention. Anybody, anyone to mention one difference? Then we continue. Anybody, any one of you?
Yeah. Please, in the first intention, the scar being healed is small, and the second
What
intention,
is
the
small?
scar is bigger.
Yes.
The scar
That
form is bigger in the
is the
second
last.
intention, but in the first intention, the scar form is very small.
That's okay. What else?
Hello, sir.
Yes.
In the first intention, it has a very clean scar surface.
Very good. So it's basically due to a surgical incision, and the wound is what? Clean, isn't it?
Yes, sir.
Yes. Unlike the second intention, whereby the defect is large, isn't it? The tissue deficit is large.
Yes.
So it's a large wound, usually unclean, sometimes infected wound. The infected wound, they will heal by second intention. Very good. What else?
Sir, please, with the first intention, the hemostatic plug is small, and with the secondary, it is larger, since the wound is larger.
Very good. What else? How about the granulation tissue?
So that one too, with the granulation tissue too, with the first intention is smaller, but with the second intention is bigger.
Yeah, they have more granulation tissue form. Very good. Now let's look at wound strength. Wound strength. Now, by the end of the first week, usually a surgical wound, we remove the sutures. Okay, by the end of the first week, isn't it? Yes, the skin, the sutures are removed by the end of the first week. If you use an unabsorbable suture, a non-absorbable suture. Okay, so the strength of the wound compared to the normal structure, the strength is approximately 10% of the normal structure. So the skin, if you are comparing where we have cut, okay, to the normal skin in terms of the strength, the tensile strength of the tissue, within the first week, okay, it's about 10% of that of some people are. Those not paying attention, you are disturbing us. The wound strength increases rapidly over the next 4 weeks. So the rate of increase then slows at approximately the third month after the original incision. Now, it reaches plateau at about 70 to 80% of its tensile strength, okay, that persists for life. So if you look at the tensile strength of any wound, it doesn't approach 100%, okay? So once you've done surgical incision and there's wound healing, if you are looking in terms of the tensile strength of the healed tissue, okay, it acquires about 70 to 80% of the normal tissue tensile strength, not 100%. So in an MCQ situation, if you are asked that by the fourth month or by the end of the third month, the wound acquires tensile strength of between, then you are supposed to know that what? Tensile strength of 70 to 80%, it persists for life. Okay, that's the highest tensile strength a wound may acquire over life. Okay, not 100%. The tensile strength compared to the normal tissue is just 70 to 80% of the tensile strength of the normal tissue. So take note of the 70 to 80%. It's featured in your exams. Now let's look at the factors that delay wound healing. So number one, we have is what? Infection. Infection will prolong the inflammation. So once the wound is infected, it delays what? Wound healing. Then foreign body. So if you have Unnecessary, if you have a wound, you have unnecessary foreign body. Could be even sutures, could be glass, even bones, fragments of steel and all that. So foreign body on the surface of a wound would delay wound healing. Okay. Then the size and the location and the type of wound will influence wound healing. So wounds that are found in highly vascularized areas of the body, like the face, they heal faster compared to wounds found in less vascular areas like the foot. Okay. So the area, the location of the wound is important. Nutrition. So if you lack vitamin C is needed for collagen synthesis and deposition. Okay. So if you are deficient in vitamin C, it will affect what? Wound healing. Also, protein deficiency would affect wound healing. Then metabolic status. If you have diabetes with vasculopathy, it will affect what? Wound healing. Okay, so DM with what? Microangiopathy. Then if there's inadequate blood supply to the site of the injury, then it will delay wound injury. So if you have atherosclerosis, it will compromise what? Wound healing. Then steroids, hormones. Okay, steroids, prolonged use of steroids also compromises wound healing. So the other factors like age. So if you compare a child to an elderly person, children may heal more faster, more rapidly compared to the aged. Okay, the aged may have coexisting diseases that may compromise blood supply to the affected site. Now, factors enhancing wound healing. So if you treat the patient with what? Antibiotics to kill what? Infection, it will promote what? Wound healing. Then removal of foreign bodies and necrotic tissue. And that's what we do for debridement. When the wound is infected, we debride the wound, and that will facilitate wound healing. In debridement, we remove what? Foreign bodies, necrotic tissue, to improve what? Or to promote wound healing. Then suturing, secondary suturing would also promote what? Wound healing. Skin grafting, a large wound defect, okay? So we use a skin, then we graft it to the site of the wound. That also promotes wound healing. Complication, okay, so let's look at complications of wound healing. So one, excessive scar formation. So formation of keloids and hypertrophic scars. So we have pictures that are depicting these complications. Then wound dehiscence, especially after surgery, abdominal surgeries. Okay, so the surgical incision reopens, sometimes called best abdomen. Okay. So this one is just comparing hypertrophic scar to a keloid. I don't want to go into that. Okay, there are images showing hypertrophic scar and keloid. Contractures. We've already mentioned myofibroblast, responsible for wound contraction. Okay, which is a normal aspect of wound healing. However, when this is exaggerated, it leads to deformities of the wound and surrounding tissues. Okay, so the palm, the soles of the feet, and then the thorax. So this patient, as in the image, you can see severe burns on the neck and chest, and has developed contractures there. They may also develop at joints, then limiting what? Mobility around the joints. Okay. So on this note, we'll end the topic of wound healing. In the absence of any question, then we would attempt to answer these single best answer questions. Any questions? Okay, so I need someone to read the first question.
Sir,
Can anyone read the first one?
sir, please, I want to ask a question.
Okay, do.
Please, factors that affect wound healing. Please, can
Huh?
you think of lifestyle? Because those alcoholic and smokers, when they had wound, it take a long time before it heals. So I don't know
Yes.
whether you can add
Yes.
this.
So you know smoking, okay, maybe associated with what? Cigarette smoking has what? Cardiovascular risk, isn't it?
Yes, yes, please.
This will affect your blood vessels eventually. Okay? Uh-huh. It may be predisposed to peripheral vascular diseases, and then it will eventually lead to delay in wound healing.
Okay.
So
Thank you
these
very
have consequences on our health.
much.
Okay?
Yes, sir. Thank you very much.
Okay. So you are right. They affect wound healing. What else? Someone to read the question.
In an experiment, surgical incisions are made in a study group of laboratory rats. Observations about the wounds are recorded over a 2-week period using various chemical mediators. Which of the following steps in the inflammatory repair response is most likely affected by neutralization of transforming growth factor? So the answer is production of collagen. C.
Very good. And that's why I showed that slide. So you are very right. Production of collagen. Next question. Who would want to take the next question?
So a cesarean section is performed on a 20-year-old woman to deliver a term infant. And the lower,
Question.
yes, sir.
You answer the first one.
Yes, sir.
Allow someone else to read this one. Another person to read this person. The next person.
Oxygen section is performed a 20-year Oxygen section is performed on a 20-year-old woman to deliver a term infant, and the lower abdominal insertion is sutured. The sutures are removed 1 week later. Which of the following statements best describe the wound site at the time of suture removal? The answer is C. Wound strength is 80% of normal tissue.
Is that what you said?
No.
Sir,
No,
granulation tissue is
tissue
still
is
present.
still present.
Granulation tissue is
It's
still
A.
present.
Come again.
It's A. Granulation tissue is
Granulation
still
tissue
present.
is still present.
Excellent. When do you expect granulation tissue to be seen? Day 3 to day what? Day
Day
7.
7.
Day 7.
Within the first week, you expect what? Granulation tissue. So the answer is what? A.
A.
Who answered C? You were not paying attention to the lecture. The
That
first
one
week,
should be 3 months and above.
the first week, the wound strength is what's the wound strength in the first week?
10%.
10% of the unwounded skin.
By the third month, what's the wound strength after the third month?
70 to
80%.
80%.
Okay. So get it right. Next question. Who is taking the next question? Let's not waste so much time. Now we can close. So let's hurry. Who is taking the next question?
Sir, please. A 40-year-old man underwent laparotomy for a perforated sigmoid colon diverticulum. A wound infection complicated the postoperative course, and surgical wound dehiscence occurred. Primary closure was no longer possible, and the wound granulated in. 6 weeks later, the wound is only 10% of its original size. Which of the following processes best accounts for the observed decrease in the wound size over the past 6 weeks? And the answer should be B, myofibroblast contraction.
Yeah, this one a very easy question. Myofibroblast or contraction. Very good. Next question.
Labile cells include C, hematopoietic cells.
So the answer is what? C, isn't it? Straightforward. Let's go on. Next one.
Healing by first intention requires clean wound.
By first
Requires clean
intention
wound.
requires
What's the answer?
Clean wound.
You
All
don't
the
like
above.
all the
All
above.
of the above.
All the above.
All of the above.
then you don't read
All the
about it.
above.
You see people when they are afraid to choose it.
Is it?
So the answer is what? E, isn't it?
Yes.
All of the above.
Who is taking the next one?
What is the maximum strength
What
of a scar?
What is the maximum strength of a scar versus the unwounded skin? B, 80%.
Very good.
80%, yes.
80%. Next question. Next question, please.
Granulation tissue is characterized by D, numerous new capillaries and proliferation fibroblasts.
Yes, so that's E.
Which vitamin deficiency most directly impairs collagen synthesis during tissue repair? Answer is C. Hey, answer is vitamin C.
Vitamin C, which is B.
Sisters, please, when you are done answering, then you mute yourself.
So we'll call it a day. I hope you will be able to replicate these same answers in exam. You shouldn't let us down. You should make sure you get a very good score, okay?
Okay.
Thank you, sir.
Pray for us.
Yeah, definitely you get this right. Okay, so I wish you all the best. Bye-bye.
Bye. Thank you, sir.